time. الله يجزاك خير.
Thank you, Faisal, for this interesting presentation. Actually, I'd like him to continue because we feel more relaxed as we see more advances in the heart treatment. I will break for 15 minutes for prayer. We'll be back exactly 15 minutes, and for the lucky numbers, we'll have withdraw exactly 15 minutes from now. So if you are not here, you may miss.
Hello. 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 You know, some of you, they were angry from me this morning. I didn't select their names or their numbers. So they have to be ready right now. I'm going to pick exactly the number I have missed this morning.
وين الرقم 5 Number 5. Who has number 5?
عدة مرات إذا ما جت سكر.
5
ما في.
ولا
صارت لعبة. تفضل. 137.
number 137.
It is Samsung Galaxy Tab 2.
196. 196. 196. ولا 45. 45. Which come? Huh? 196. You have 45. خلاص كم؟ تأخرت الله يهديك وسحبنا زيادة.
كم رقمك؟ 196. باقي أحد؟
45. 45. So still we have more prices if you stay around. Okay, now we'll move into our last talk for this afternoon. You know, we hear a lot about Google saying that people can work at home. So I think we have a good news here that hospital will be at home. So maybe one day we'll come, we'll stay at home and do our job from there. Our speaker for this is Miss Julina Sharif. Miss Julina is head of home health care section at KFMC. She has been a registered nurse for more than 25 years. She worked in Singapore from 1985 to 2002 before migrating to Australia in 2003. She had worked in the hospital, in the home department in Victoria, Australia, and as an associate nurse unit manager for 5 years before coming to Saudi Arabia. She joined home health care department here in KFMC since May last year and had initiated nursing services programs to serve KFMC patients in the community. Some of the programs started are wound care, anticoagulation, home infusion therapy, palliative and general nursing care programs. She's still working in initiating more programs that benefit our patients in KFMC.
Assalamu alaikum and good afternoon. I feel honored and privileged today to be here, and I would like to thank the organizing committee for inviting me to share my experience with Hospital in a Home. I'm lucky that my slides are colorful because this is the last presentation, so I hope it'll keep you all awake, and just bear with me. Hospital in a Home. History of home care. Home care began at the end of the 19th century, where nurses worked in the homes to help new mothers and treat people with infectious diseases. And now, the concept of home care is spread all over the world, with each country built it based on the pertinent needs of the country's health system and the community. And some of the common factors as to the increased emergence of home care services around the world is the increased age population, and it is considered as a cost-effective alternative to hospital care. Hospital in a Home in Victoria, in 1994, it was a government-funded pilot project to encourage public hospitals to provide a substitute to acute hospital care in community settings, including patients' homes and residential aged care facilities. In 1996, the government provided another 20 million over 4 years to further develop this home-based care. There is no international definition of what hospital home care is, but there is a consensus that the key features of a hospital in a home program should be that it is the provision of care that is a true substitute for hospital care. The care is provided in a place of residence. The services of healthcare professionals are used in the delivery of care. Therefore, consequently, hospital in a home care should reduce or eliminate an inpatient stay in a hospital facility, is similar to care provided in a hospital facility, is clinically appropriate care, and is not provided by usual community-based services. So hospital in a home being a substitution for hospital accommodation, the patients are actually not discharged from the hospital, but rather they are being transferred to a virtual ward where they call it the hospital in the home unit of the individual hospital. So with every hospital in a home, there is a eligibility criteria, being clinical stable and the home environment is suitable. And at the same time, because a nurse has to see a patient every day in the ward, so with the patient in hospital and home, the nurse actually has to visit them daily as well. The programs and services provided by this hospital depends on what the hospital, if it's the bigger the hospital, the bigger the programs and the more variety of the services is provided. But in 3 broad categories, the services that can be provided in hospital in the home are actually just administration of IV fluids or drugs. It can be either from antibiotics to chemotherapy, the anticoagulation program, which is an acute anticoagulation, and also the complex wound care. In 2009, the Department of Health Services in Victoria did a review of hospital in a home program, and they concluded that it is a well-established model of care, it is safe and effective, it is a preferred modality for a core range of conditions, and it is highly valued by patients, caregivers, and staff. Being a hospital in a home, any of the clinician is able to actually refer a patient for hospital in a home care. The aim of the HIF service is that the quality of treatment received is equivalent to that received in the hospital environment, including access to an appropriate range of clinicians. But hospital in a home itself is actually a short-term care because it is the acute phase of treatment, but once the patient has left and has met the goal of care, they then have to be transferred to other community-based care. In Victoria itself, there are a few, there's a few actually community-based care which these patients can be referred to. And as I've mentioned earlier, hospital in a home depends on whatever the hospital is. These 4 services actually part of the hospital in the home program. The breast care nurse actually looks after the breast cancer patients, and these patients are normally discharged on the second post-op day, and they'll be looked after by a nurse who visits this patient at home. The domiciliary services are actually the maternity, the new mothers, and also the premature babies. And the REIT is actually the rehab in the home where patients, for example, after a total knee replacement are sent home after a few days, and then they are being visited by the physiotherapists, occupational therapists, and the rehab nurse there to provide the care. The recipe is actually the residential care integrated program for the elderly, because majority of the elderly patients are in residential aged care. So they will get the GP to actually look at this patient in the aged care homes, and if this patient would require some form of acute treatment, they wouldn't send this patient back to the hospital, rather they will admit them under hospital in a home so that the nurses can actually visit them and provide the care. So once this treatment is finished and the patient still require ongoing care because of their condition, they would be referred to other community services such as a post-acute care where it's a different funding, and the nurses would just go there for a maximum of probably 4 weeks. And if from then they still need further care, they will then be again referred to another kind of a home care, community service. So the general practitioner or the GP plays a vital role in Victoria because all patients discharged from hospital are followed by a GP, and they manage these patients and follow up these patients at home. If the patients happen to come to the clinic and they need some kind of acute treatment, for example, a short course of antibiotics, the general practitioner can actually refer these patients to hospital and home where the treatment will be provided at home. Plus that if, let's say, if the patient happens to be a chronic patient who needs long-term care, the Royal District Nursing Services will then take over the care of the patient and continue looking after the patient till as and when they need it. HAP is a hospital admission risk program. This for patients who are having chronic cardiac and rehab condition, and they are visited by nurses who actually go them and assist them and to actually prevent them from being readmitted to the hospital for their chronic conditions. And we have the pathology who plays a vital role because those patients on anticoagulation, for example, for INR monitoring, the pathology actually send the phlebotomist to these patients at home, or they could actually go to the pathology for the INR monitoring. They don't even have to go to a doctor because there is a hematologist who is attached to the pathology to actually dose the warfarins for this patient. Those patients who are LD and choose to stay at home, they are usually very independent. They are pretty much on their own. So if they are if they have had fallen ill and need some time of a temporary care, they would seek the home help. They are actually personal carers who are being sent to these homes to help them with their showering, with their shopping, and also they actually provide meals for these patients until they fully recovered. So Hospital in a Home itself, it is a fantastic program because it actually gets patients out of the hospital early, but at the same time, it's only for a short-term period, and they really need to have this whole other community service to actually support the patient to give it a real holistic care. Just to touch a bit of the Hospital in a Home Society, which actually look at the development of in the models of care and clinical guidelines development for the hospital in the home across Australia, so that it will be standardized. And these are run by doctors and nurses and allied health. And it provides education and promotes networking through its executive council. I'd just like to bring your attention to the Royal Children's Hospital in Melbourne. It's a brand new hospital built last year, and I really like the home care program that they have, which they call it RCH at home, because they have everything under the roof. They have the short-term support, that is the hospital in the home that I mentioned, and they also have the medium-term support care, that's the post-acute care, so patient will be transferred from one care to the other care. For the long-term support care for these children, they do have the family choice program where they actually being cared for to assist the families of these children with complex chronic medical needs to be cared for at home with their family. They have the school care program where this is for children and adolescents who would not be able to attend school without specific medical intervention, and where training for this medical intervention is required. Then they have the home care program, which enable children and adolescents with ongoing interventional medical care needs to be safely cared for in their home environment. And of course, they have a big palliative care program, which is coordinated by the Victoria Pediatric Palliative Care Program to just enhance the quality of life for the child and support for the family. So let's come back to Saudi Arabia. In Saudi Arabia, home care has started for about 30 years, and as the rest of the world, it has spread across the whole of the Saudi Arabia in all the provinces. In Riyadh itself, home care has been pioneered by the National Guard Hospital, the Riyadh Military, and the King Faisal Specialist Hospital. And within the Ministry of Health, home care has started since 2009. So let's come more closer to home, that is in KFMC, home care in KFMC, where we are at the moment. We have a car, a nice one, and where do we want to go, and how far do we want to go? When I first came here last year, May, the respiratory home care has already been established. So I was telling myself, well, okay, let's do hospital and a home. One of the first questions that I really asked is actually, what are the community services that you have for the patients here? And they tell me, none. So I said, okay, let's take a step backwards. And we actually take a few steps backwards to actually look at the whole picture, what is in need of KFMC patients. When I started, I inherited about 100 patients from the respiratory program, and we looked at the needs of these patients at home who are not visited by nursing at all, and we came up with a few programs after that to add on. I realized that I could not take what I did in Australia to be practiced here, basically because of the difference in the culture. For example, I would take 1 week to teach a patient on wound care back in Australia, but here it took me 6 months to actually teach a family member to do wound care for the patient at home. So we started this program, the wound care, general nursing care, anticoagulation, palliative, and home infusion therapy to add on to the other existing services. And all these programs are actually chronic programs because all the patients that is referred to us are more of the chronic patients. But then again, these programs are actually designed so that we can actually accept acute patients as well. So whenever we are ready, then we will be going ahead with it. Accepting another example of the cultural differences is the acceptance of these patients to be cared for at home, and also taking responsible for their own care, and also for the physicians, whether are they going to refer us these acute programs because they are not sure whether we are able to be coping with it. I'll show you an example of two of the patients that I have. This is a patient that we've seen for INR monitoring, and he's a stroke patient. He's got a left-sided weakness. And look at him, he's quite happy there, lying on the floor. And if you can see the medical bed that we provide and the air mattress behind him, maybe one day I will, be able to talk him onto getting onto the bed. But at the moment, he's happy there, and we are happy to be on the floor with him and giving this care for him. One of the things that he always tells us when we go and visit him was, I couldn't remember what the Arabic term is, but is a liar. And why would he say that we are liars? Because whenever we go there, we would tell the patient and say, if you exercise and you move your arms and legs, and then you will be okay. But I do not blame him for saying that we are liars, because doing his exercise, as his wife said, is only the time when we are there for a few minutes, and then that's it, until the next 2 weeks, and he'll do it again. So for this group of patients, what can we do for him? Are we able to provide some physio for him so he will be able to make use of his legs again? are we able to provide him some occupational therapy so one day he could actually sit up and have his meals with his family? Or we could send a speech pathology to assess his swallowing and his speech. And also some personal care at home so that they will be able to care for him. This is another patient, but this is not my patient. I have a patient who has the same genetic condition as this boy, which is achondroplasia. So just imagine him. I did not have a permission from his father to show his photo. He's a 4-year-old boy. Just imagine a smaller version of this boy. We're in a 2-year-old body. He has at the same time chronic lung diseases, and he's on a tracheostomy and also a nasogastric tube. Now, he's been seen by our fantastic respiratory therapists for the care of the tracheostomy, teaching the family and support them in actually doing the suctioning. And the nurses would come every 2 weeks to change his catheter, his NGT. He cannot stand or he could not walk, but he could sit very straight upright, and he is, mashallah, he's a very intelligent boy. He knows when we want to change his NGT, and whether he sees the nurses, he will just, do this without saying anything, because we know that it's going to change it, and it's so uncomfortable for him. When we go into the patient's homes and we look at all these children, and we look at the way the mother cared for them with those tender, loving eyes for these kids, we just can't help it and wanting to do something more for this patient. So with this boy, can we provide him some physio so he'll be able one day to ride this bicycle? Or could we give him some speech pathology so that he could learn to speak and eat normally? Some occupational therapy perhaps, so he can make full use of his arms and legs. But the most important thing is that I want to send him back to school. Can we do that? He might not be able to grow as a normal adult, but he might be able to do some great things in life later in his life. So our vision, or more like our wish list, is being made not because plucking up from any list, but it's based on the needs of our patients at home at the moment. At the moment, we might have KFMC at home. These are all the services that we have. We have the nurse, we already have the respiratory therapist, we have the social worker, and we also just got a physician. So can we send in the whole rehab team in there, occupational therapists, physical therapy, and speech therapists, because of the patients that we had, the stroke patients, is quite a number of patients out there who really need this. Can we send a pharmacist in there? Because whenever we go for home visits, patients will show us 2 or 3 bags full of medication, and they didn't know which one they've taken or which one is the one that the neighbor told him is a better medicine to take rather than the one that's prescribed from the hospital. We need to have a case manager in order to coordinate all these services for our patients at home. And also, we need a clinical dietitian to go out there and assess all these patients, because we have so many patients on the enteral feed, and also patients, diabetic patients who are non-compliant to the diet at all. Yes. Okay, we like to have a call center who actually to take all the calls that's coming through for our patient, and transportation is one of the most important thing, because most of the patients did not come back for review just because they couldn't get the patients in back to the hospital. Telemedicine would help. Instead of our doctors going out, we could do a video consulting on over the air, and also home health aides. One of the reasons why patients are being sent home early are not being sent home is because of problem having personal care. Yesterday, there was a question about why the patients does not want to go home. Maybe the answer is because they are afraid, and they are afraid that they are not able to look after their loved ones at home, and they don't know how to, and that's usually the reason. But if we can convince these patients that all is provided and they have nothing to worry about, probably then no one would want to stay in a hospital to be managed. So we still have our car. It's a matter of which way we want to go. And I think that's a question that we need to answer. Thank you.